Hello everyone, I'm So-Ick Jang from Department of Pediatric, Sejong General Hospital, South Korea. It's my great honor to have an opportunity to present in front of distinguished other cardiologists. The topic for today is congenital heart disease and device closure, a pediatric cardiologist view. However, in the subtopic for this session includes PFO, ASD, and LA appendage. I have slightly modified the title, Transcardiac closure ways in elderly patients. In previous session, the anatomy and imaging and technical issues were discussed, so I don't want to address this topic in my presentation. AS in elderly patients present several important issues distinct from the pediatric cases. First, the question arises, where to close it, when is the optimal timing, and what the effect of closure would be. Additionally, there are critical concerns such as post-closure heart failure, arrhythmia, and pulmonary hypertension. Let's take case one. A 67-year-old male patient with the adult cardiology department to mild chest discomfort. Although no abnormality were found on TMT, moderate size ASD discovered an echocardiography, and device closure recommended. However, the patient continuously repeated the treatment. Over the next 10 years, the patient experienced worsening dyspnea and low limb edema leading to revisit. This time, the patient agreed to proceed the treatment. In 2012, chest X-ray mild cardiomegaly observed, and 2015, it appeared to slightly progressed. However, after 10 years later, 2022 chest X-ray showed significant cardiomegaly along with severe pulmonary congestion. In 2012 echocardiography, mild RV enlargement and mild TR were observed. However, 2022 echocardiography were revealed severe RV dilatation and moderate to severe TR. Fortunately, after several months of medical treatment, device closure was successfully performed. Follow-up echocardiography showed improvement in RV dilatation and reduction of TR to mild severity. This is guideline from AHN ESC, which recommend closure when RV volume over compound or QPCS is 1.5 or higher, as well as the RP is less than 3 with the unit, or RPS ratio less than 1/3. Even elderly patients, it has been observed that following device closure, the frequency of dyspnea and palpitation decreased, while objective measures such as exercise duration and VO2 capacity increased. Additionally, improvement in mental score has been confirmed. Additionally, after device closure, RV dilation and deduction of RV size are observed, along with the improvement in 6-minute walk test. And Nakayama et al. Reported negative relationship between RV dilation and exercise capacity, suggesting 120 cc per square meter as a cutoff value for RV dilation. As seen aforementioned patient, another critical issue TR. Fortunately, many studies report moderate to severe TR decrease to mild moderate severe level after device closure. Age has been identified as the important predictive factor for this improvement. This study showed TR significantly improved in some patients despite sigma TR at baseline. Moderate to severe TR post-closure is best predicted by a combination of factors including age, RA size, RBC pressure, and extent of RV dysfunction. Additionally, the moderate to severe post-TR is associated with significant adverse event. Moderate to severe residual TR has been reported an important factor for new onset AFib, new onset heart failure, hospitalization, and all-cause mortality. Therefore, continuous follow-up is essential. This is system review and meta-analysis on transcardiac closure of ASD in elderly patients, which clearly demonstrates improvement in New York and reduction of systolic pulmonary artery pressure and decrease in TR severity in following device closure. Let's move to the second case. A 76-year-old female patient visits our hospital for incidentally discovered ASD. Echocardiography revealed a large secondary ASD, approximately 30 mm. However, the patient lacked posterior inferior limb, which posed a high risk of embolization and with device closure. So, surgical treatment was decided upon. Chest X-ray revealed cardiomegaly and pulmonary congestion, and while ECG showed the sinus rhythm and tall and wide P wave. Cardiac case was performed. QPCS was 4.6, and mean pulmonary pressure 24 mm mercury, and PVR is 1.8 with the unit. Additionally, LV EDP is elevated at 60 mm mercury. Based on this finding, surgical closure was penetration with planned, and there is no perioperative event. However, 1 month after surgery, the patient presented with continuous dyspnea and palpitation, and EC showed the atrial flutter, for which cardioversion performed successfully converting rhythm to sinus. Let's look at the third case. The 60-year-old male patient was diagnosed with ASD 10 years ago, but did not receive treatment. Recently, he developed dyspnea and visited the hospital. Echocardiography revealed moderate-sized extra-condom ASD, approximately 20 millimeter, and it was decided to proceed to transcatheter closure. Chest X-ray revealed cardiomegaly and pulmonary congestion, and EC showed sinus rhythm. 24 millimeter device was used, and after confirming stability through the legal test, detachment performed. Did you notice anything unusual? Yeah. Yes. Immediately after detachment, the patient developed atrial fibrillation. Arrhythmia is relatively common in elderly patients with ASD, and RV volume overload and resulting structural remodeling can lead to fibrosis and electrophysiological abnormality in both atria, which may cause atrial fibrillation and flutter. Additionally, mechanical stress, inflammation, and scarring associated with the device can lead to re-entry tachycardia, sinus node dysfunction, and complete heart block. As shown in this diagram, AS can lead to rhythm arrhythmia through structural remodeling, electrical remodeling, device-related problem. A recent published meta-analysis reported transcatheter closure AS does not significantly reduce the prevalence of arrhythmia, and in particular, provide no benefit for a patient aged 60 and above. In addition, it has been reported that age at the time of treatment and BNP level are associated with new-onset atrial tachyarrhythmia. Studies have shown the incidence of 6% of patients over 40 years old and 12% in those over 65 years old. This table summarizes the risk factor for arrhythmia occurrence after device closure. As reported in various studies, these factors include age, gender, metabolic syndrome, thyroid disease, pre-procedure arrhythmia, BNP level, systolic pulmonary pressure, RV dysfunction, and PAV duration, and so on. Look at the first case. 55 years old male patient visited the hospital for incident discovered ASD. Echocardiography revealed the large ASD, measuring the 40 by 15 millimeter with moderate to above TR and pressure gradient exceeding 100 millimeter mercury. Consequently, further workup, including cardiac case, was planned to evaluate pulmonary hypertension. During initial care, mean PAP was 50 millimeter mercury, and QPQS was 1.9, and PVR was 5.1 of the unit. So medical treatment, including ERA and PDE5 and initiated. However, after treatment, repeated case showed no significant change. Therefore, it decided to perform another case and proceed to surgical partial closure. After partial closure, follow-up case showed a similar result. However, 4 years of continuous medical treatment, another case was performed, and the result was judged to slightly improved compared to the previous finding. And this is a cardiac case performed 8 years after surgical partial closure. Although pulmonary hypertension is still present, but mean pulmonary pressure decreased to approximately 40 millimeter mercury, and test occlusion showed a reduction in both pulmonary pressure and PVR. Following conference of discussion, closure using penetrating device was performed. As a result, mean pulmonary pressure decreased 35 millimeter mercury, and PVR decreased 3.3 of the unit. This initial echocardiography of patient showed RA, RV enlargement, moderate to severe TR, and flattened the ventricular septum. Following device closure, penetration flow has been maintained, RV size decreased, TR amount decreased, and interventricular septum slightly mild globular shaped. The prevalence of pulmonary hypertension in ASD patients is reported around 5%. Treatment decisions are typically based on factors such as PVR or RPRS ratio, but in some cases, making an appropriate judgment can be very challenging. A recent multi-center study from North America presented result of treat to close approach for AS patient with pulmonary hypertension deemed non-repairable. This result showed the repaired group demonstrate improvement in 6-minute walk test, pulmonary pressure, and PVR compared to unrepaired group, ultimately impacting survival outcome. Additionally, treat to repair strategy reported Takaya et al. Shows similar result, demonstrating improvement in near-class and systolic pulmonary pressure. This is my take-home message. Transcatheter closure of AS is safe and feasible in adults, including elderly. There are several important issues in AS and elderly patients differ from those in children and young adults. Cardiac remodeling, tricuspid regurgitation, arrhythmia, pulmonary hypertension, and post-closure heart failure. Patient selection and careful pre-evaluation very, very important. Preconditioning and balloon test occlusion are recommended to prevent post-closure heart failure. For arrhythmia, transcatheter closure is not associated with reduction in prevalence of atrial arrhythmia. It showed small benefit in patients above 40 years old, but no benefit in above those in 60 years old. When pulmonary hypertension present in adult patients, very careful and step-by-step approach is essential. Thank you for attention.